All right, let's go ahead and get started. I'm sure some people will filter in as we go, but I want to go ahead and get this rolling. Thank you for joining us. I'm really excited to present this. I've been wanting to do this actually quite a long time. But so let's get on with it. So today we're gonna be talking about Melillo method. It's something we do here in the office. Essentially, it's a brain-based approach to treating neurodevelopmental disorders through basically an area of science called functional neurology, and that is essentially the idea of creating neuroplasticity in specific areas of the brain to help correct imbalances and improve symptoms. So, just a little bit of an introduction about me. Again, I'm Dr. Matthew Zaideman. I'm a chiropractor, I'm a certified functional medicine provider, and I'm also a fellow of the International Board of Functional Neurology in Childhood Neurodevelopmental Disorders. And when I, went through this, one of the things I also did was get certified in this specific method called Melillo method, which we'll be discussing more as we go through. We also have an occupational therapist who unfortunately wasn't able to join us tonight. She had a family emergency that she couldn't get here. But we're really happy to have her on board and use her expertise as well in conjunction with what we do. She started with occupational therapy back in 2016, where she graduated from Kaiser. And then she also spent several years in the Leon County School District. She actually did some work with my child when he was in the school system. She also has a Bachelor of Science in Occupational Health and a Master of Science in Occupational Therapy at Kaiser in Fort Myers. She graduated in 2022. And she also completed a capstone project with a focus on disruptive behaviors in school environment. Sarah's taken a variety of continuing education courses related to neurological rehabilitation, autism spectrum disorder, ADD, ADHD, and also sensory processing. We're super happy to be able to incorporate those more traditional occupational therapy services with what we're doing here as well. So let me tell you a little bit about my story about kind of, why I'm doing what I'm doing. This is my son, Jacob. He is shockingly now 10. I can't believe I'm looking at this little kid here. But so he was developing completely normally. At this point, I was pretty new in practice, a chiropractor. I did some functional medicine. I'd worked with kids with autism from a functional medicine standpoint. And he was going around just perfectly, pretty normally. I don't think we had any concerns. And about right around 18 months of age, he just stopped talking. He stopped talking. He regressed in several different areas. Fast forward a little bit, he did get diagnosed with autism, was nonverbal, probably up until 4.5. And, in that time where he's getting diagnosed, we were recommended occupational therapy, speech therapy, all your traditional things. But, one thing that got me was no one was really able to tell me, hey, what is going on in his brain? Why is what I'm seeing symptomatically? Why is that happening? And finally, I was recommended a book called Disconnected Kids by Dr. Robert Melillo. And I read that and it clicked with me. It made sense to me that this is a great explanation of what I'm seeing. This is what's going on in the brain that's creating these symptoms. And the other thing I realized was when we think about autism, we think about ADHD, when we think about other, developmental disorders, for the most part, there are, yes, you can have genetic diseases where you're going to create these types of symptoms and get diagnoses that could be autism or other stuff. But the vast majority of kids who have this, if we do an MRI of their brain, structurally, it's completely normal. There's nothing wrong with their brain. It's just how it's wired, how it's connected. So even though I love our occupational therapists we work with, we love our speech therapists, we we love all of the team that we have, there wasn't much on telling me how can I change his brain? How can I reconnect these areas? And when I read this made sense. This is something that we could do. And so here I am, and I'm hoping to share this with as many people as I can because it's been a game changer for us. Our son can now talk. We can have communication. We can, conversations. simple conversations become conversations with him now. And there was a time where I didn't know that was going to be possible. So let's go ahead and get into some of the things we're going to cover tonight. We're going to go over some of the most recent statistics, the prevalence of ADHD, autism, other neurodevelopmental disorders. I really want to be able to also give you guys at least a basic idea of what areas of the brain are basically imbalanced, and that can help. To me, it was really helpful to know, hey, why am I seeing the symptoms I'm seeing? And so I hope that we can give you at least a basic understanding of that. Learn about retained primitive reflexes. Primitive reflexes are something that's a kind of a foundation of neurodevelopment and something I think that's it's very important. And then we're going to teach you about a concept called of hemispheric dominance and hemispheric weakness. And then we're going to learn about Melillo method, which is basically a treatment modality where we can take these weaker areas of the brain, stimulate them, help them connect, and then make these kids the best versions of themselves they can be. So first of all, let's look at where we are with neurodevelopmental disorders. As of now, according to the CDC, greater than 1 in 6 children, 3 to 17 years of age, in the United States have at least some sort of neurodevelopmental disorder. So somewhere between 16 and 18% is the current estimation. It was 12% in 1997, 15% in 2008. So it is steadily rising. And we've especially seen this in autism. ADHD, autism spectrum disorder, learning disabilities, and other developmental disorders are the most common. So if we look at ADHD in particular, the prevalence of that is now up to 11.4% of children. That's 7 million kids in the United States have this diagnosis. And that was up 1 million from the last time they did these statistics. So it's increasing. Boys are more prone to be diagnosed with this than girls, 15% versus 15% of boys have ADHD and 8% of girls. As far as autism, we are shockingly up to 1 in 36 kids. Um, that is really shocking when you look at the context that in 2000 we were 1 in 150. So in just basically a quarter of a century, we've gone from 1 in 150 to 1 in 36, which is really, really disturbing to me. So, why is that happening? Part of it's going to be, increased awareness. We're doing a lot more of early intervention and testing. But, I think there's probably other environmental factors, other things that are happening there. We're still learning about that. But I think there's more to it than just increased awareness and diagnosis for sure. And I think if you ask any school teacher who's been in the game for a few decades, you're going to see that they notice it. They see it in the classroom. This is not what it used to be. And there's something happening here. I mean, I think definitely our food is part of it. Things in our environment, even stress to both during pregnancy and after. I think we're going to see a bigger spike, following the pandemic for multiple reasons. But it's something that we need to look at for sure. This is also interesting to me. This is services utilized by children who have been diagnosed. And it was pretty crazy that, anywhere from, between urban and rural, anywhere from 41 to almost 50% of children with these diagnoses are getting no services whatsoever. 80% are going and seeing their pediatrician, but, less than half at least close to half of them are not getting any kind of therapies whatsoever. We experienced that to some degree when we saw, some of the regressions with our own son. And, there was the usual, well, he's a boy, he might take longer to talk, let's wait and see. And to me, that is the worst thing you can do. Listen to your gut feeling, especially you moms out there. That mom gut feeling is usually pretty spot on. So there's no reason to hesitate and wait on getting some early therapies. If you're wrong, grow out of it anyway. The therapy is not going to hurt them. It's only going to quicken the process. So that's something that I'm really passionate about. And I think that's super important. Real quick, I want to talk about some of the CDC developmental guidelines that change. I mean, to me, some of the developmental guidelines are something that we can really look at and see if development's on the right track. And in February of 2022, they were changed for the first time since 2004. So what they've done is instead of the milestones based off what 75% of children can do, um, they are now basing off what 50% of children can do. So what that means is they're basically lowering the bar. Being having some delays that are mediocre are now considered somewhat normal. And to me, we should not be lowering the bar. We should want all of our kids to be optimal. It should be more of the thought process. Crawling has been removed as a milestone altogether. So now, if your child does not crawl, that is considered completely normal. Um, to me, that is crazy. That is there for a reason. And the only reason they're saying that is because more kids are skipping crawling. We're also getting more kids with neurodevelopmental disorders. So if kids are having more issues, why are we now making it where the warning flags are now less evident? Walking has been moved from 12 to 18 months. Talking has been moved from 12 to 15 months. Sitting without support, 6 months to 9 months. Using the use of 50 words has gone from 24 months to 30 months. Now, to be fair, the argument here from the CDC, the reason they changed that is what their argument is that, well, when kids were missing milestones, a lot of them weren't getting referred, they weren't getting services, and we showed that that is, the case probably on the last slide. But and so what they're trying to say is that, hey, if they're missing these milestones, hey, they need to be referred. They need to go out. So they're trying to make more of a standard guideline. But heck, why don't we just do that on the previous guidelines that we had? That would make a lot more sense to me than this. So this is just something to be aware of, especially for those parents who maybe just had a child and are concerned about what's happening. That is something to be aware of, that these guidelines have been minimized, and I think it's a mistake. So, real quick, let's talk about the neuroanatomy. I'm going to focus mostly on ADHD and autism. We're going to touch on some OCD, dyslexia, some things even with sensory processing. We're going to touch on that. But I didn't want this to be 2, 3 hours long. I didn't want this to be a weekend seminar. So, we're going to focus on some of the main disorders that we see and focus on that. And then, we will touch on some other things and kind of go from there. So the first part of the brain I want to talk about is the basal ganglia. The basal ganglia is basically something that really we've only concerned about with motor movement in the past. So it is responsible for balancing out how we move our bodies. And there's essentially two parts of the basal ganglia, the direct pathway and the indirect pathway. And so if you think about the direct pathway, that is something that is going to create movement. So these two systems are always ongoing and they're always, well, supposed to regulate themselves. So essentially, the direct pathway is always telling your body to move. And then you have this indirect pathway, which is more of the brake pedal. So if you think about direct pathway is the gas pedal, the indirect pathway is the brake pedal. These are constantly being stimulated, firing to balance out where we only make movements when we have to or want to. But what happens in a lot of neurodevelopmental disorders is there's an imbalance between these two systems. The direct pathway is mostly mediated through dopamine, the indirect pathway more through GABA, those neurotransmitters. And when you have an imbalance, especially in ADHD and autism, and where you have more direct pathway than indirect pathway, then you get these unwanted movements. These can then look as tics or stims, or maybe this is where kids just literally cannot sit still. They've always got to be moving. This is also why you can see things like wobble chairs and different accommodations like that to try to calm these kids, because those things naturally moving them calms their nervous system. And so this is the reason, this is the underlying neurological imbalance into why these things are happening. Not only that, let's talk a little bit more about, even though this is all motor movement, we now know that there is several what we call prefrontal connections. So the frontal lobes are responsible for some of our more complex motor movements, emotional behavior, cognitive functions. I like to joke, it's kind of a part of the brain that separates us from the animals, okay? It's really what makes humans humans as far as the brain goes. And what's important to realize is these parts of the brain don't exist in a vacuum. They don't just function on their own. They work in loops. They work in networks. And some of those networks connect directly to the basal ganglia. And so if you have imbalances from that real primitive part of the brain, the basal ganglia, then you're going to end up very, very likely with some imbalances in these frontal networks as well. So there's five of them that we really kind of focus on, and we're going to break those down. The supplementary motor area is mostly involved with motor movement. You have the frontal eye fields, which is more saccadic eye movement. So that's rapid eye movement. So, if I'm got my fingers up here and I'm going to look back and forth very rapidly, those are saccades. And then you have the dorsal lateral prefrontal cortex that's over here on both sides, of course, and that's more involved in executive function. You have the orbital frontal, which is in the front, and that's more involved in social engagement and a few other things that we'll break down. And then you have the anterior cingulate, which is more involved in motivation. So let's start off with the supplementary motor area. That's an area of the brain we call Brodmann area 6. And Brodmann areas are, I won't bore you into that, but basically, there was a scientist who went down and noticed that certain parts of the brain had, at a cellular level, different appearance and also related to different functions. Essentially, it is mostly involved in motor activity, overactivity in the left hemisphere of that Brodmann area. So if you have it overactive here, that's going to directly stimulate that direct pathway. So again, that's going to cause those unwanted movements, motor tics, stereotypical behavior. So if you think about autism with hand flapping, those are all things that we can see in ADHD, autism, Tourette syndrome. And if you think about it too, this is also why you get kids with these multiple diagnoses, right? Because you're getting areas of the brain that are involved. If you have a child with autism, you could have this area involved in the brain and fit the diagnostic description of ADHD, autism, and Tourette's. So that's why that happens. It's not necessarily separate issues. It's all part of the same complex, some same functional imbalances within the brain. Overactivity in the left hemisphere and underactivity in the right is also connected to hyperactivity, obviously, because it's going to create that additional movement. The frontal eye fields, this is Brodmann area 8, more on the top kind of frontal area. This is going to be involved in saccades. Those are eye movements that are rapid, so we can actually measure it that way too. That's what's cool is we can have technology that measures these movements to help identify where the weakest areas on it. And what's cool about this, part of the attention network, so sustained attention that can be an issue with ADHD, is lateralized to that more right hemisphere. So if we see poor saccades, and then we also know there's attention issues, we can start to not only focus on what areas of the brain we need to stimulate, but what side. And that's going to go into some of our hemispheric imbalance discussion. The next one is the dorsolateral prefrontal cortex. This is Brodmann area 46 and 9. And again, on both sides, kind of in here-ish. And that is going to be involved mostly in executive functions. So to be able to multitask, to be able to do all those types of executive functions. And the right hemisphere also stimulates that hyperdirect pathway. Now, the hyperdirect pathway is what is going to go directly into actually the indirect pathway, and that also inhibits that direct pathway. So again, and I know this gets extremely confusing, but to back up, stimulating that right dorsolateral prefrontal cortex is going to inhibit those unwanted movements of that direct pathway. Let's move on to orbital frontal cortex. That's in the front. And this is Brodmann area 10 and 11. It's heavily involved in social engagement, contributes to sensory integration. And again, that right hemisphere is going to activate that hyperdirect pathway, inhibit that direct pathway. And that's another one that does that. It's also involved in inhibiting unwanted or inappropriate emotions, social behavior, thoughts. So things that we see like OCD. Also, if you have that child who doesn't realize personal space, so they're if you guys ever watched Seinfeld before, they're the close talker, right? They get it right up in your face. That's usually this part of the brain, okay? And so if that is immature or not functionally connected like it should be, there's a weakness there, then you can have those types of symptoms happening. So we can also test that area of the brain because it's also involved in processing our sense of smell. So there's actually validated tests where we can, it's a really cool test. It's actually it's great for kids. It's, basically markers that smell like different scents. It's pictures, multiple choice. So they'll have let's say you get a marker that smells like coffee, they'll get a little card that has coffee or fish or oranges, and they can pick that. And then we can validate and measure where their sense of smell is. And if we know that's off, then we really know that there's probably a weakness in that area of the brain, especially if they have some of the symptoms that relate to its function. The next area is the anterior cingulate. This is heavily involved in motivation. Again, the right hemisphere activates that hyperdirect pathway. It inhibits that direct pathway. So it's also going to um, calm down that overactivity part of that nervous system. So kind of the pattern you're seeing here is just like we talked about the direct and indirect pathway, the left brain, and we'll talk about this more, is the gas pedal, and the right brain is more of that brake. And so that ends up kind of giving you a better understanding of why kids are hyperactive, why they can't sit still, why they can't control their bodies, and where do we need to stimulate that. And we're going to go into how and why we do that. That is, can be help minimize those symptoms and hopefully make them, diminish without stimulation. Once we get that kind of wired, then that can be an ongoing improvement. Stroop test is a test we can use to actually test the anterior cingulate. And this is an example of Stroop test. And essentially what you would do is you would put this up and then you would have, and you can do this with adult. And of course, you have to augment this if you had a younger child who couldn't read. But essentially what you want to do in this situation is have them read the color of the font. In this example, read the color of the font they see, not the actual word. So instead of saying purple, red, brown, red, green, blue, you would want them to say green, brown, blue, purple, red, green. And if they hesitate, if they pause, if they say the actual what the word says instead of the actual color, then you mean there might be some sort of issue there. Okay, moving on to a little bit different areas. We're kind of out of those prefrontal connections. I'm going to move to an area called the primary somatosensory cortex. This is basically an area of the brain, and it's over on both sides, up in here, more part of the parietal lobe. And it's basically a map of our entire body from left to right. Okay. And so you can see on here when we look at this, if you start at the top of the head and then move down out to the side, then this is where your body realizes where all your body parts in space are. And the right hemisphere in particular, in another area called the insular cortex, processes all this information for both sides of the body. Um, and what's interesting is one of the theories that I subscribe to of why kids with autism are nonverbal is oftentimes not because they don't have active language centers of the brain, because that's mostly on the left, but it's a processing issue to where they can't literally feel their mouth and tongue to make the movements. Because a lot of these kids, you put them in front of a computer, you put them on a typewriter, or where there's all kind of different, technology that we can use to help these kids communicate. I mean, there's nonverbal adults out there who are brilliant and can write these unbelievable, they have all those words inside them is what my point is. And they can type it out, they can do it all these other ways, but there's a disconnect between the brain and to the actual motor areas of where you verbalize this. And so that's kind of a different way of thinking about that. But that's something I've seen to be true with a lot of kids with nonverbal autism. And so there's some different areas that we need to do to activate that and hopefully get them talking, that's what happened with our son. Okay, so that's kind of some of the basic areas of the brain that we kind of focus on. We're going to be talking more about some specific areas as we go, but I want to get into the nuts and bolts is what is it that we do? What is Melillo method? And essentially, it is a way to address these neurodevelopmental disorders and other behavioral and learning disorders by focusing on two major concepts. One is retained primitive reflexes, and the other is hemispheric imbalance. And what that means is that one hemisphere is dominant and one hemisphere tends to be weak. Now, I believe we're all kind of like that. A lot of us are either more left brain people or right brain people, and that can give us our personality, that can give us some different skill sets. That's why I like to call this an unevenness of skills. I think autism, ADHD, all these things are more unevenness of skills than they are diseases or disorders. And while that can give us super skills, I mean, you can see kids who, I know a kid who has, has autism and can tell you, I've heard these stories through training I've done, who can tell you, you tell them a president, and they can tell you the day of the week and the year they were born, like that, because it's a basically a sequence that they can a pattern that their brain can automatically process. It's wild. That's where savants are. The engineers are probably very strong left brain people for the most part. So they can come with skills, but also at the expense, if you get under connection on the opposite hemisphere, they can create some weaknesses. And that's why some of us are better at other things than others. So it's not about this therapy is not about changing these kids as far as who they are. It's about creating balance. And I think that's what we all want with our mental health or some of our weaknesses. We want balance. We want to be able to keep our strengths, but strengthen our weaknesses. And that's exactly what we do. And we do that through sensory stimulation, integrating primitive reflexes, and creating neuroplasticity, which is new connections in those weaker areas of the brain. So that brings me to neuroplasticity. What is that? That is essentially creating new neurons and new connections. And we know we can do that. What's fascinating is we know we can do that into our 80s now. So even adults with ADHD, anxiety, depression, these things we can still help those by identifying these underconnected networks and stimulating them. Now, in order for this to happen, there's a couple things that we need. We need movement. This is why movement is so important with young children. Sensory stimulation, and then we need metabolic demand. And what I mean by metabolic demand is, if you think about your high school biology classes, we need to be able to create basic ATP, that cellular energy. So, I mean, if you have B vitamin deficiencies, if there's inflammation, all these things can block that from happening. And that's why some of these other environmental issues can stop normal neuroplasticity and normal development, is because you might interfere with how the mitochondria can make energy. Because if you can't make energy, then your body can't do anything. And so that's really important. And so we're always going to keep that in consideration and try to assess that with each patient that we treat. So primitive reflex, why are they so important? Because they are the foundation of neurodevelopment. Primitive reflexes help then develop into our sensory motor cortex. Then our sensory motor cortex then develops into our frontal lobes. And that's what's going to regulate cognition, being able behavior, involved in the academic issues. This top of the pyramid is really where parents come to me for. They don't come to me for normally, I got retained primitive reflexes because no one's really checking that. We just assume they go away. But this is really super, super important to go after in any context. Just like I said before, these areas of the brain are involved in networks. They're not working in a vacuum. All right, so let's go briefly through some research. This first one is talking about ADHD associated with certain primitive reflexes, asymmetric tonic neck reflex, symmetric tonic neck reflex. There's several reflexes and this is through a systemic review, a meta-analysis. So this is a study of the studies. All right, so there is unbelievable research that's coming out like crazy, and literally, if you ask me, if you went through this 20 years ago, there was hardly any. And so this is very emerging field looking at this, but it's becoming more and more evident that this is part of the picture. This was a study that was done with children with retained primitive reflexes and basically showed improvements on cognitive, sensory motor, and academic performance in ADHD. So, integrating these primitive reflexes showed an improvement in listening comprehension and mathematical problem solving. And finally, this study shows retained primitive reflex in autism spectrum disorder. And again, this study goes through some of the same concepts that these reflexes help develop motor skills, which is a lot of your developmental milestones, right? Crawling, walking, all those types of rolling over. Those primitive reflexes integrating help those milestones actually happen. So if your child doesn't crawl, there's a good chance that maybe they didn't crawl because they retained a primitive reflex. So that's really important to think. And then when they're retained, that literally means that there is some level of cortical somewhere in the brain. There's some immaturity. There's some disconnection that's happening. It may be mild. It may work out to be a weakness towards anxiety, or depression, or it could be something that's a warning sign for something bigger. We don't know, but we should be looking at these primitive reflexes and integrating them as we go for sure. So I'm briefly going to go through the different primitive reflexes. I won't spend a ton of time on this, but give you some idea. Most of the symptoms you're going to see with these reflexes when they're retained are going to be motor skill type things, things you might have seen when your child was younger, depending on where they are now. But the asymmetrical tonic neck reflex is the one we have probably the most research on and the one that's most connected. Probably the one most common one I see by far is going to be involved with balance issues, cross lateral movements. So think about issues crossing the midline, activities like riding a bike, and also poor eye tracking, hand-eye coordination. Handwriting issues can also be involved with this. The Moreau reflex, this is the startle response. If you ever seen a baby go like this, or you see those adults where you barely sneak up on them and they jump, that's sometimes a retained Moreau startle reflex. This can be some of the hypersensitivity or reactive type of symptoms we see. So, especially with, I know my son had horrible, horrible issues when he was young getting haircuts. He had a strong Moreau reflex at the time. There's also fear paralysis reflex that is even more primitive to this that sometimes is still involved. Poor impulse control, motion sickness, being timid, anxiety, sensitivity to light, sensitivity to sounds, or dislikes, changes, or surprises. So getting out of that routine. The spinal galant reflex, this is a reflex that helps the baby actually get out of the birth canal. So especially something we're looking for if we have a history of C-section. Sometimes it's understimulated, so it doesn't go away. But this can be related to symptoms of fidgeting. Bedwetting is a big one with this. Poor concentration, short-term memory issues, and also postural issues, especially postural issues, so slumping to one side. The next one is symmetrical tonic neck reflex. This is one of the ones that was in that study with ADHD. Poor posture, especially. It's really involved with those kind of postural spinal muscles. And then what we call a simian walk. So, people who don't move their arms when they walk. Okay, that can be a sign that that reflex is retained. The tonic labyrinthine is involved a lot with the development of the vestibular system. Our vestibular system is that inner ear balance. So if any of you all have had vertigo or motion sickness or anything like that, that's your vestibular system that's in balance usually with that. That can be again involved with poor posture, poor muscle tone, visual spatial perception issues. So, and that's big with vestibular. So, if you're that person who walks the doorway and is always hitting their shoulder, poor visual spatial perception. Poor sequencing, not a big fan of sports. Poor sense of time actually can be involved with this reflex. The land reflex is more of a postural reflex. This is something that we see, and it's usually related to some of these other reflexes not being integrated. But this can mostly be coordinational issues with things like hopping, skipping, jumping are hard for children to do. But again, mostly a motor skill issue. The palmar reflex, this is the grasp response. If you ever put something in the baby's hand, they just kind of grab onto it. That is something that's really involved with development of some fine motor skills. So poor handwriting, Actually, speech difficulties, because there's another reflex called the Babkin response. And that's when a baby, gets something in their hand, they almost want to automatically come to their face with it. So that kind of hand to mouth relationship also can be involved in some speech issues as well. The rooting reflex is involved in feeding. So this helps a baby, especially with breastfeeding. So when they get a stimulation to the cheek, they're going to want to turn their head and automatically go to feed. This can be involved with issues with speech and articulation, poor manual dexterity, and that goes with the Babkin response as well, if that's retained. And also, if you had tongue ties, lip ties, some of those things early on, there's a bigger chance that I find, clinically at least, that these things could be retained. So real quick, I want to talk about a case that I had that was really interesting when it relates to the root reflex. This was a 4 month old. It was actually a foster child who was premature, very sadly born with methamphetamine in their system. They were in NICU. They had some issues. They were really having trouble doing any feeding and very tight. And what was interesting was I saw no root reflex. I mean, it was getting to the age where the root reflex actually should be starting to decrease, but I saw none at all. And that seemed unlikely to me. So I said, hey, let's stimulate this anyway. So we did. And within just, really a week, 2 weeks, when that child came back in, that root reflex was totally active. And so this was actually a situation where this child was so delayed, this reflex, which should have started to come on while the baby was still in utero, hadn't come on at all. So it's not like this reflex was an issue that it got retained. It just hadn't even been active yet. And once we got that reflex active, the baby started feeding and started improving from there. So a really good kind of interesting thing where these reflexes, just because we assume they're going to come on, there can be things that create them not to come on from a further delay. All right, let's talk about hemispheric imbalance. This is when we're going to talk about left brain, right brain. So, what I want to do is kind of give you some ideas of what each side of the brain does very generally, not going into a ton of detail just for time purposes. But the left brain is going to be more detail oriented. The right brain is more big picture. The left brain is more verbal communication. The right brain is more nonverbal communication. And that's important. The right brain develops first. You're not going to have verbal communication until you get nonverbal communication. Left brain is more fine motor. The right brain is going to be more gross motor. The left brain is going to be more IQ, more intelligence, and the right brain is going to be more emotional intelligence, being able to read people. Positive emotions are going to be more left brain. Negative emotions like sadness is going to be more of the right brain. Left brain is more conscious actions and memory. So that's like why you learned something. And unconscious, right brain is more unconscious actions, memory, and learning. So that's things you learn and remember, and you don't really remember how you knew that or why you did it. You just know it. That's something that happened almost that you heard at some point, but you don't remember why, but you know it. Left brain is more auditory processing. Right brain is going to be more tactile processing. Left brain is going to be more linear and logical. This is why we see a lot of engineers, science type people, in general, math people who are going to be left brain dominant. And then right brain's going to be more understanding that abstract concepts. And so that's just kind of a small showing about how we can see. And both these things you need. So it's all about balance. It's not like one side's better than the other. They're both obviously skill sets in both of those. But now we can kind of see where a dominance in one at the expense of the other can create some issues and create symptoms. So let's talk about some of the research from this concept. So this was a really cool one. This is a study that was done independently by Harvard Medical School, and it looked at essentially primitive reflex exercises along with sensory stimulation, so stimulating one hemisphere over the other, and something called interactive metronome, which is something we'll talk about a little bit more, and how that impacted ADHD. And which was really interesting about this, they treated these kids over 15 weeks. And they also did something called quotient testing, which that actually looks at kind of hyperactivity. And they also used the revised Connors parent rating system for ADHD on this. And the treatment actually resulted in, first of all, when we look at hyperactivity, what you see on the top here, let me see if I can get this, get my laser pointer here. On the top here is pre-treatment. So this is the quotient. So this is looking at head movement. So it's basically a tool that Harvard uses when they're looking at ADHD to look at hyperactivity. And this is the quotient system testing they did. And this is over 5 minutes, 10 minutes, and 15 minutes. And you see how the hyperactivity improved. This was post-treatment. And so what was crazy about this was the final part of this study showed that it was the for as far as ADHD on the outcomes on the Connor scale, they showed the same improvement they saw with ADHD medication. So it was just as effective. But one thing we do see with ADHD medication traditionally is it doesn't tend to help the hyperactivity part of ADHD. It helps with attention, but oftentimes does not help with hyperactivity. And that's what was cool about this. This showed pretty strongly that we saw improvement with hyperactivity. More so, what we saw, and this is the coolest part to me, this is kind of the new areas, what you're seeing in the red and blues, the new areas of the brain that were connected through functional MRI. So they didn't just use those two things, they also did functional MRI, which actually can show you how the brain actually wires. And post treatment, they're actually able to show increased connectivity in those areas of the brain that we know that are involved with ADHD. So when you reconnect these areas, this is going to be long lasting improvement. Now, we go through and stimulate kids and stimulate kids and stimulate kids. We can have improvement and then we back off and we might see small regressions because it's hard to know when it's fully integrated versus it's better because you're stimulating it. But over time, that will become more and more ingrained, and the improvements become more and more lasting. Okay, so this next study looked at the relationship between retained primitive reflexes and hemisphere connectivity in autism spectrum disorder. And essentially, we looked at QEEG, and that means we're looking at brain waves. Okay, so this is another objective way to kind of see, are you changing the brain? That's why I got into this. This is why I do this, because it's about changing the brain, creating more balance in between these networks. And essentially, what they did was they put a TENS unit, which is an electrical stimulation. If any of you guys have back pain, you may have had someone put a TENS unit on for pain. We do this at a proprioceptive level, which means we just do it until the child can feel it. And that activates certain parts of the right or left hemisphere, depending on which side you put it on. Did that along with stimulating some of the primitive reflexes. And then this study looked at essentially how did the brain waves change. So real quick, let's talk about brain waves in general. Delta waves are more of the slowest brain wave. This is what we see in deep sleep. Theta waves are more involved in interoception, something we see in meditation. They also can be related to memory. Gamma waves are more of the fast brain waves. This is involved in a more cognitive function, attention, memory. And then alpha waves are more involved with alertness, calm focus, and cognitive function. All right, so let's look at these. First of all, when we see basically what you're seeing here is the before and after treatment on these. Before treatment, we actually saw a increased delta power, and this was lateralized on the right hemisphere. This is autism because that's kind of some of our leading theory of behind our method is that autism has more of a right hemispheric deficit. And so we see more of, and this is upon waking. So this would be totally normal if this child was asleep. But if this child's awake and alert and doing things, and we see a lot of delta waves on this right side, that means that side is not firing like it should be. And after treatment, we saw a bigger reduction in those delta waves. So we saw a change in the actual wave pattern. These are theta waves power. Before treatment, we saw a increase of theta power. Again, something that would have been okay if we were meditating or more towards sleep. But after treatment, we saw a great reduction, especially in those frontal areas. So again, as far as in the context of being an awake and alert, this was a big improvement. Gamma power, we saw an increase. Again, this would be something we want to see high in alert and functioning. We saw it quite decreased in the frontal areas. And then after treatment, we saw an increase. Alpha power, the same thing, a decrease pretty much globally. And then when we saw the decrease globally there after treatment, we saw an increase, and especially an increase more on that right hemisphere, especially. Here's another something I want to describe. It's not only about one hemisphere and this hemisphere. Again, just like the other networks we talked about, these networks don't exist in a vacuum. Okay. One of the things we know about autism is that we have more short range connections. The brain's just functioning in more in little vacuums. Where the brain gets more complex and more developed and more balanced is when we have more long range connections. So we're connecting and regulating in between the hemispheres. So it's not just about strengthening one hemisphere, it's getting them to work together. Okay. And so that's what we saw in all of these delta, theta, alpha, and gamma bands. On the left is before treatment, the right is after. And we see these more vacuumed like connections. And then after treatment, we see them crossing the hemispheres. They're starting to regulate each other. They're crossing over, there's integration happening. And that's also a very important concept to understand. So, how do we do hemispheric stimulation? We use sensory input. That's how you do it. So that could be vibration, that could be a TENS unit, that can be sound, light, smell, all these different things we use. And oftentimes we'll use all of them. Sometimes depending on what part of the brain we want to stimulate, we might lean more heavily on one versus the other. And so these are all areas. And then some of them we do same side, sometimes we do opposite side. But doing that in a way that biases it to the weaker hemisphere is the key to this sensory stimulation. Here's kind of an example of what we typically will do to create that sensory stimulation. Hopefully this works. And basically what you see is you have tens on the left side. In this game in particular, the headphones the program actually sets it up to play sound in one hemisphere or one ear versus the other, depending on how we want to stimulate more the right brain or left brain. We're also using a vibration plate to create vibration. And then we're also using something called transcranial stim. And essentially, the red wire is
Good
stimulating the
job.
weaker hemisphere, and the black wire is going to more inhibit that more dominant. All right, let's move along. I'm going to get into some more type of things that we use. One thing that is very common that people know about autism is this gut-brain connection. In mental health in general, there's a lot of talk about gut-brain connection, anxiety, depression. That's something that's getting a lot of focus. And there's some wild research out there. I mean, we now know that concussions, and this is a study I have linked here, a concussion can actually create what we call hyperpermeability, or some people know as leaky gut. I think that's kind of a bad term because obviously all that stuff's not leaking into our systems where we get sepsis and die. But leaky gut or hyperpermeability means proteins and peptides can get through that can create an inflammatory response, malabsorption of nutrients. And when that happens, the reason a concussion can create that is because of what happens to the intervention and tone of a nerve called the vagus nerve. What regulates that gut brain pathway is a nerve called the vagus nerve. So, vagus stimulation is something that's very important. It can help regulate our parasympathetic nervous system, it can help decrease anxiety, it can help lower inflammation throughout the body, and it also helps mature the vagus system. Polyvagal theory is something by a PhD named Stephen Porges who talks about two parts of the vagus nerve. The dorsal vagal, which is the more primitive, pure survival. Think about the freeze response. And the ventral vagal, which develops kind of after that first year of life, which is more social engagement, feeling safe in their environment, being able to interact with people. And he developed this through the context of like PTSD, trauma, and that is 100% true. That can cause that to be um, imbalanced and go back to this more primitive ventral vagal versus dorsal vagal. But also, we're understanding that also this can be purely developmental. That system didn't develop, and we definitely see that a lot in autism. And what's fascinating is if you when you learn about this, it also has a lot to do with a lot of physiological gut movement, constipation, GI balance, your nervous system. A lot of research about doing vagus nerve stimulation now and even autoimmune disorders because neurologically, this helps regulate the immune response so it doesn't overreact or underreact. So this is something that I think is very, very important and incorporating this. And some of this can be linked back to that retained Moreau reflex. That's why it could not have developed the way it should have. But doing vagus nerve stimulation along with it is something that we find to be very helpful. We measure it using heart rate variability. I won't go, I know I'm running a little bit on the late side, so I'm not going to go crazy into the nuts and bolts on how this works. But essentially, it measures the balance between our sympathetic nervous system, which is our fight and flight, and our parasympathetic, which is more sleep, digestion, rest, repair. Kind of what makes us young, kind of relates to that fully developed polyvagal system. So another case that we did that was really fascinating to me, this actually kid came in with just stomach pain. And it only happened at night. It was very interesting. Not necessarily related to any food, just stomach pain at night. And so, we're wondering if there's some imbalance in the gut flora or inflammation going on there. So we did what we call a test called a GI map. And so this is also something that I do. I do these functional medicine tests, stool tests, organic acid tests, metals tests, things that are we having some inflammatory effect. And we had some mild bacterial overgrowth, some mild things that might have been involved. But this child also had a lot of severe allergies. And so, with that, the parents were very hesitant to give him any kind of herbal or any kind of, things they didn't know what how to react because when they try new things, they go to the ER parking lot because he had such bad allergies that anything new could theoretically create an anaphylactic type of reaction. Couldn't even hardly tolerate some of the allergy shots he was getting. So what we decided to do, because of his HRV test, showed a big vagus nerve imbalance. We just stimulated that vagus nerve. We did that through a pulse radio frequency device that we use called StimPod. We did that once a week for 8 weeks. And then what we saw on the results, this is his HRV. And when he goes from laying to standing, we see this huge increase. Up and down is his fight and flight response. Left and right is that parasympathetic, which is that's what's kind of regulated by the vagus nerve. And we saw this huge shift. Really, this should be just a very small 1-to-1 ratio. Very small, okay? And then after treatment, this is what we saw. Not perfect, but a whole lot better. Not as much hyperregulation. And what we saw also after that time frame was his pain got totally resolved. We were totally eliminate that. We did digestive enzymes essentially, but that's pretty much all we did on that side of things. And that has been lasting. That hasn't come back on him, and it's been a very awesome, successful treatment. We did it neurologically. We corrected some gut stuff neurologically, which I think is something to keep in mind, especially with this huge connection between the gut and autism. That is a real thing. Don't get me wrong, but it's important to realize it's a two-way street. The gut can improve autism, no doubt. I've seen it, I've done it, but also sometimes you got to stimulate the top down as well. It's the chicken and the egg that has to be dealt with. The next tool we use is interactive metronome. This is a really cool tool that has tons of research. It's been around a long time. Lots of occupational therapists actually use this. It's even used in stroke recovery as well. And it's basically based off timing, neurotiming, and synchronization of these neural impulses. And that has a lot to do with the synchronization of the hemisphere and something we call temporal processing. So this can help with everything from cognitive function, communication, sensory and motor performance. The applications are really wild and broad. And then this is a study that kind of goes into that. So this was actually a study on dyslexia. I promised you I was going to throw dyslexia in there somewhere. But essentially, this was showing that music training increases phonological awareness and reading skills in developmental dyslexia. And this was a randomized controlled trial. And part is that when you way music training helps is that neurotiming, having to keep a beat. That's what we do with interactive metronome. Obviously, playing an instrument can do some of these same things. But one thing we see in dyslexia a lot is temporal processing issues. That's part of the brain that's involved in that. And so that's one of the things we can use to really help improve that. Okay, last thing we're going to talk about, and then we'll be wrapping up, is something called photobiomodulation. This is low-level laser. Red light therapy is what a lot of people know about it. When it's used on the brain, unbelievable. And this is actually, I should have put it in here, but there's a study out there called Shining Light on the Head by a researcher at Harvard. who goes through all these mechanisms. This is actually an image from his kind of study that where he compiles all the research and goes through the effects and how it works. But red light actually does, when you put it on the head, it will penetrate the skull and it will create neurogenesis and synaptogenesis, which is a fancy way to say it creates new neurons and new connections. So, especially when you know where the weakness is and on what side, and can put that light in that area, then you can really focus that improvement on the proper areas. I will tell you that I got a lot of pushback from my wife getting this laser to do this because they're not cheap. But when we did that, and that's is probably the one thing along with everything else we did, but this is what rapidly increased our son's speech more than anything else we did. And I don't think she'd disagree with that at this point. But it's awesome to use thousands of studies using this in traumatic brain injury. And also, we now have a double blind study on using it in autism itself. And when we look at this study in autism, essentially what they used was baselines on the aberrant behavioral checklist. And what this study looked at four different categories in that checklist: global irritability, social withdrawal, stereotypical behavior, hyperactivity, and inappropriate speech. And what you're seeing in these graphs is this top line is the placebo, okay? No improvement across the board. The rest of the kids, I think every kid in the study except for one, I think in the treatment group there was 15, 17 kids, so relatively small, but most studies are with kids. We saw decreases across the board. This was done 2 times a week for 4 weeks. What was really cool too is that after the 4 weeks, they stopped treatment but reevaluated these kids again. They kept improving. So you see this 4 week to 8 week trend continued to improve these symptoms across all of these categories. And the reason that's important is because when you're creating neuroplasticity, you can keep that improvement going because you're rewiring the brain. So red light is going to have, I think, a big place in this going forward. I think the research will continue. It's extremely safe. There's really the only side effects that really have been documented with this is mild headaches post-treatment. Last case I'm going to show you, this was really cool. This was an 18-year-old I saw who was diagnosed with autism, had just started some classes at TCC. Well, when it was TCC, I guess we're Tallahassee College now. But this was something we call right eye. So this is measuring eye movements. Now, our eye movements, we're not talking about visual acuity. So we're not talking about 20/20 vision versus 20/40 vision. We're not talking about that. We're talking about how our eyes move together. So can we track? Can we fixate? Can we make those rapid eye movements? And the reason we do that because those eye movements are controlled by different areas of the brain, but also each eye is controlled by other area or a separate side of the brain. Okay. And so when we look at this pursuits, you see the imbalance between left and right. So that shows that hemispheric imbalance to me. When you see one eye moving different than the other, that can be not always, there can be other issues that cause that, but that can be an indication of that hemispheric imbalance. So we saw that here in pursuits quite dramatically, saccades as well, the fixations we see off centered there. We did once a week for 12 weeks. We did all those things I just showed you. And these are we saw the improvements in those eye movements. His mom told me he started being able to drive himself to school. He was able to start interacting with his classmates in groups, was making friends, grading function. And so again, this is not about changing these kids. It's about creating balance, making them more functional, being able them to be the best versions of themselves they can be. And it's just cool to see that happen. And this isn't going to just go away. You know, if he has a head injury, God forbid, or something like that, then yes. But these are going to be lasting changes. All right, so that's what Melillo method is. That's how it works. That's how we can do it. That's the research behind it. I appreciate you guys kind of hanging in there with me. I know I went a little bit later than I anticipated. Is there any questions? I'll check the live stream on Facebook here too. And this might be some people on there as well. Okay, I don't see too much. Either I bored you to death or it made perfect sense. But either way, I'm so happy you guys joined. If this is something you want to pursue further, get some more information on, I do free consultations. So if you want to do that, just contact our office. Our number is 850-877-6790. You can also go to our website at healthytallahassee.com and look at some more videos. I have about a longer version of some of the research, kind of another breakdown of this as well. So feel free to go look at that. But anything I can do to help you guys out and give you more information to help you help your kids, I'm happy to do that. So again, thank you for joining, and I look forward to doing this again in the future. Have a great night.